you for asking me to speak to you today. I hope you can hear me. We've had a few texture. I'm a consultant cardiologist at Queen's, and today about pacing for the non-cardiologists. So in terms of objectives for today, I want to see modes you might encounter. I want to go through what the procedure entails and some basic electrical concepts, some complications you might encounter after pacemakers have been implanted, who to pace, some cautions that need to be adhered to for patients with pacemakers having MRIs or surgery or cardioversion. And I'm also going to touch briefly about other types of cardiac device. So pacemakers are very common, and you can see on this graph there's a trend to increase in implant rate, which probably reflects the aging demographic. In terms of the components of the pacemaker system, is essentially a battery or a pulse generator and a couple, and wires, and the circuit may or may not involve the body tissue. The pulse generator or battery tends to be made from lithium, and the battery longevity is typically around 7 to 10 years, and that will depend on how much the pacemaker is being used. It'll also depend on how efficient the pacemaker is, what the amount of energy it needs to. The leads are insulated wires, and they can essentially do two things. They can either sense what electrical activity is occurring,
sorry,
in the
doctor,
heart, and they can pace. So that's the only two.
Sorry, Dr. Said, you're breaking up. What might be useful is if you turn your camera off, hopefully that might help with the audio. Because it's really breaking up. I could barely hear the sentences. So if you put your camera off, that might help.
Is that any better?
That's much better, yeah.
Is that any better?
Yes, it is.
Do you want me to go back on that?
Yes, please. Yes, please.
Is that clearer?
Yes, it's much clearer.
Shall I carry on where I'm from, or shall I go back to the? Is it? Shall I go back to the start, or shall I carry on?
Yes, please. I would say if you can kindly go back so that for those who were not able to catch some of the things you've said, we'll have we'll just
yes.
Give them
just
a
let me know if you can't hear it.
All right, we'll do.
Yeah, my name is Saad Sahicha. I'm going to talk about pacing for the non-cardiologist. In terms of the objectives of the talk, I'm going to discuss what a pacemaker entails, what the procedure involves, some of the basic electrical concepts, some complications you may encounter after a pacemaker implant, the indications for pacing, and some cautions to adhere to with regards to MRI, surgery, and cardioversion. I'm also going to touch on other types of cardiac device. Can you hear me okay?
Yes, we can. It's much better. Thank you very much.
Good, excellent. So pacemakers are commonly implanted in the UK and Europe, and you can see this trend to increase in implants, and this is likely to reflect the aging demographic of the population and increased conducting disease. In terms of the components of the pacemaker, this is essentially a battery or a pulse generator, and the wires or leads and the circuit may or may not include the body tissue. The battery or pulse generator depends on how efficient the circuit is, and also how much the pacemaker is needed to be used. And the longevity typically is around 7 to 10 years. The leads are insulated wires, and they can pretty much just do two things. They can sense electrical activity in the heart, and they can pace the heart. And those are the only two things that a pacemaker can do. It can sense and it can pace. You may come across the term unipolar pacing system. This is a sort of old-fashioned, the wires, the battery, as well as the body tissue. The more new devices are bipolar, so they equalize to the tip of the pacemaker. So yeah, there's two different types of leads you might come across: unipolar and bipolar. The leads are transvenous, and so they are within the venous system of the heart. There's two types of leads that are commonly used. And they're passive and active. Does anyone know what the advantages and disadvantages might be of these leads at all? Well, the passive leads are leads that are put into the trabecula of the heart. They don't actually they have tines on them, so they are not actively fixed into the myocardium. So the advantage of the passive leads is there's less risk of perforation, but the active fixed leads, there's less chance that they will become displaced. So we tend to use active fixed leads the majority of the time, but passive leads may be considered in elderly patients who more risk of perforation. You might also have come across epicardial leads, but these tend to be used post-surgery or in paediatrics. So you're probably less likely to have them. In terms of the different types of pacemaker, this is primarily based on the number of leads that are present. So with a single chamber pacemaker, this is pretty much a VVI pacemaker, which is a single lead in the ventricle. This is the electrical activity within the heart, and you can see a pacing spike there, and then a ventricular pace beat, and then you can see the sensed activity, and then another ventricular pace beat. And this is the simplest type of pacemaker that's commonly used in patients with slow atrial fibrillation. The second type of pacemaker is a dual chamber system. This is where you've got a ventricle, and this helps to provide synchrony between the two and gives pacing support in both the atrium and the ventricle if needed. So here, there's this chest radiograph shows a dual chamber pacemaker with a lead in the right atrium and the lead in the apex of the right ventricle, and you can see the generator that sits on top of the muscle under the skin. And here's a lateral view which shows the right heart anterior and the pacing leads in situ. The system, which is called a biventricular pacemaker, atrium, one in the ventricle and one in the left ventricle, one in the right ventricle, and one in the left ventricle via the coronary sinus. And the CRT is a treatment for heart failure, and it aims off the heart.
Sorry, the voice is breaking again.
And this X-ray shows with a lead in the right atrium, lead in the apex, and the LV lead through the coronary sinus on the left-hand side. Can you still hear me okay?
Breaking up. You're still breaking up. Well, we can still hear you, and yeah. Can everybody hear Dr. Said? Yeah.
It's breaking up time to time, but we can guess what you're saying next. But yeah.
Okay.
Just yeah. So in terms of the pacing modes, the two that to be familiar with are BVIR and DDDR. The pacing mode refers to which pacing chamber is paced, which one is sensed, the response to sensing, and rate modulation. So with the simplest type of pacemaker, a VVI pacemaker, the chamber that's paced is the ventricle, the chamber that's sensed is the ventricle, and the response to a sense beat is that it inhibits pacing. So pacemakers are quite lazy. They only work when they have to work. So they try to encourage your own intrinsic. VVI pacemaker rate is set at 60. So you can see on the diagram, you have a paced beat, and this then sets off a timer for a second. And if there's no intrinsic activity, there'll be a further paced beat. You can then see after that paced beat, there is intrinsic activity within the that's detected by the pacemaker, and this causes it to be inhibited, and it resets the timer. VOO mode is what happens when you put a magnet over a pacemaker, and that just causes it to pace at a fixed rate, regardless of doing during surgery. DDD mode, you have pacing and sensing in both the atria and the ventricles, and there's sort of 4 different scenarios that might be encountered in a beat, and then there's a delay. If there's no activity, then you get a ventricular pace beat. So the first scenario is atrial and ventricular pacing. The second scenario, you have an atrial pace beat, and then you have a delay, but then there's the patient's own intrinsic ventricular. The third scenario, you've got your own intrinsic atrial activity, and then there's a delay. There's no ventricular activity, and so the pacemaker works. So that's A sense V paced. And in the last scenario, you've just got the patient's intrinsic activity, A sense V sense. So the pacemaker looks to encourage the heart attempts to minimize pacing. The R component, so VVIR or DDDR, is the rate response. So the pacemakers have a mechanism by which they can respond to increased exercise by increasing the rate. So this acts as a physiological response. Are you still able to hear me okay?
You're breaking up. You're still breaking up. That's fine.
Hello?
You're still breaking up.
Are you able to hear me?
I can, but no, some sentences are cut off. But can other people hear Dr. Said?
Intermittently, it still breaks, unfortunately.
Mm.
Yeah, I'm struggling to. You're breaking up as well.
Anita is saying she can hear you okay, but I think a number of us, the audio is intermediate, and
Okay. Shall I carry on? Or
yeah, I would say yeah.
yeah, okay. So in terms of the pacemaker procedure, this is usually done in the cardiac cath lab, and we get access into the heart through one of the veins, either the cephalic vein or axillary vein, and the wires are placed into the heart under X-ray surveillance, and they're either screwed into the heart if they're active leads or put in passively. And then there's a generator that sits, or the battery that sits on top of the muscle under the skin. So in terms of complication perforation, the leads themselves can perforate through the heart. The leads can displace. You can get hematoma and bruising, and also infection is a risk. We give prophylactic antibiotics to try and minimize the risk of infection. In terms of the parameters that we check during the pacemaker, we essentially check two components. So the sensing, what the pacemaker actually sees, and the threshold, it's the amount of energy that the pacemaker needs to capture the heart. And those are the two main components that are checked. So the wave, or in the case of the right ventricular lead, would be the R wave, and that's what that's what the pacemaker sees, or said integrity of the circuit. So the integrity of the circuit from the leads to the box. The pacemaker threshold is the amount of energy that's used to capture the heart, and the lower the threshold, the more efficient the pacemaker. So in terms of the patients that would benefit from pacing, there's good guidelines in the 2013 ESC guidelines on pacing and cardiac resynchronization therapy. So essentially, the patients who want to pace are the ones with symptomatic bradycardia, and this can either be a persistent bradycardia or an intermittent bradycardia. If it's a persistent bradycardia, then it's quite straightforward. You can pick that up from an ECG. If it's an intermittent monitoring, or an implantable loop recorder, which is a small device that's put under the skin that can monitor the heart rhythm for up to a few years. But the key thing is about correlating symptoms with the bradycardia. The sinus node disease is disease that affects the sinoatrial node, and this can occur as pauses in the heart rhythm, and also chronotropic increase with exercise. There is no prognostic benefit for pacing with sinus node disease, but it's helpful when the symptoms can be attributed to it. So in terms of the different types of sinus node disease, if sinus pauses are usually less than 3 seconds, and sinus arrest is usually greater than 3 seconds. And if this correlates with symptoms, then that would be an indication for a pacemaker. Also, if patients, you get quite elderly patients who have got quite a sluggish heart rate profile on a 24-hour tape, and they can't get their rate up, and so that may be another indication of sinoatrial node disease, and they may benefit from a pacemaker. In terms of AV block, atrioventricular block, pacing is indicated for prognostic purposes in both third-degree heart, irrespective of symptoms. Now, for first-degree heart block, this can be a normal variant, and this isn't normally, this isn't an indication for pacing. for second degree AV block type 1, which is Wenke back, and that's where the PR interval gets progressively longer and then you miss a beat. That isn't an indication for pacing. The cases where you would consider pacing for prognostic grounds are type 2 second degree AV block, is where there's complete P wave activity. So here in the top trace, you can see 2 P waves for every QRS. So that's 2 to 1 block. And also in complete heart block, where there's complete dissociation between the atrial and ventricular activity, that would be grounds for pacing. So sinus node disease and intermittent AV block are indications for pacing. So other indications may be AF with a slow ventricular response and symptoms. Tachybrady syndrome, where you're trying to control the faster, and so you want to give them a safety net of a back. If they've got evidence of conducting disease on the resting ECG and unexplained syncope or trifascicular block, that may be an indication for a pacemaker. And also, and this is usually patients who haven't responded to other treatments, you burn the gearbox, so they will have a pacemaker and then they have an AV node ablation, and that helps to render them free of symptoms. Pacemakers can be used in MRI scanners safely, but you need to check all the components. So the leads have you have to check them pacemakers are MRI safe. In terms of surgery, surgery and pacemakers can be done safely. In some instances, particularly with heart's own electrical activity, and that can suppress the pacemaker. So dangerous. So in those patients, the device asynchronous, and so it just paces regardless of the activity it detects. Pacemakers can be done safely, or cardioversions can be performed safely in patients with pacemakers. You need to ensure you place the paddles a reasonable distance away from the device and interrogate the pacemaker after the cardioversion. It's probably not recommended to cardiovert a patient within the first 4 to 6 weeks of a pacemaker, because that could theoretically dislodge the leads. And then the leads take about 4 to 6 weeks to mature and embed in the heart. So unless it's an emergency, I wouldn't recommend cardioverting until after 6 weeks after a pacemaker. In terms of other cardiac devices, there's the cardially used as a treatment for patients with heart failure who have got poor left ventricular systolic function, so ejection fraction less than 35%, and a broad left bundle branch block. And this response to treatment is determined by the breadth of the left bundle, because that indicates the level of dysynchrony. And these patients are usually patients that are on optimal heart failure medications and are usually NYHA class 2 to 4. So the patients that get the most benefit from CRT are the patients, as we said, with a wider QRS, non-ischemic cardiomyopathy, because there tends to be less scar and you get better pacing parameters. And there have been numerous trials that have shown a mortality benefit and a benefit in reduction in hospitalization for heart failure, and improvements in quality of life for patients with CRT. And for the patients that have a CRT, around two out of three respond quite well, and they notice an improvement in the symptoms. And there's about a third of patients that don't get the full benefit of the CRT. And the reason for that is that they may have been poorly selected in the first place. So they may have had a narrow QRS. They may have other medical comorbidities that preclude them from that mean they're breathless anyway. So that they may have underlying COPD. They may be anemic. The position of the lead may also be a factor. If there's a suboptimal lead position, then you might not get the full effects of the device. In terms of other cardiac devices, ICDs, they can pace and sense just like pacemakers do, acting as a defibrillator. So they are primarily implanted to treat fast, dangerous heart rhythms. They're not implanted for pacing, but they can pace if need be. So an ICD can sense and detect dangerous heart rhythms, and it can provide pacing relation therapy. So they treat abnormal heart rhythms such as cardiac death, and it's important that patients with ICDs are told that it won't help to improve their cardiac death. So I often say to patients, it's like wearing a seatbelt. You're not going to know that you're going to need it, but it's there in case you do. And you've been identified as a high risk patient. So the patients with an ejection fraction of less than 35%, particularly with a history of ischemic heart disease, or that would be a primary prevention indication for an ICD, or patients who've had a VT or VF arrest in the absence of a reversible cause. They would be patients you would consider for a secondary prevention ICD. And the ICDs and the CRTs have device diagnostics, and so the patients usually have a CareLink device that they can put in their bedroom, and that downloads to the device and that gets transmitted to the pacing clinic. So such as whether the patient's had some episodes of non-sustained VT or arrhythmia. Devices have also got some fluid status monitoring, so they can tell whether the thoracic impedance goes up and whether the patient may end up having an exacerbation of heart failure. But in practice, this monitoring, this fluid status monitoring isn't that accurate, because it can go up with other things such as chest infections. So the devices can be monitored remotely to look for arrhythmias, look at the heart rate profile of the patient, and look at how much pacing percentage they are using. So in summary, pacemakers are common. They can be for symptomatic bradycardia. There's a prognostic benefit in higher degree AV block, so complete heart block and second degree type 2 block. There are certain precautions to be adhered to with surgery and cardioversion and MRI. CRT is an evidence-based treatment for heart failure, and ICDs are used to reduce the risk of sudden cardiac death and treat VT and VF. I can take any questions if you can hear me.
Yes, we can hear you. I'm going to stop the recording because we've got a number of questions already in the chat box.
Yeah.
Let me just stop the recording.